Good day, and a warm welcome to all of you. Thank you for giving us your time today to join this webinar. My name is Hans-Pieter Snels, and I'm the Product Director at DEBx Medical. We will keep this session practical. Today, we will focus on surgical site infections and their burden in wound care. Our guest speaker has significant experience in these wounds and understands the challenges that arise with post-surgical wounds that become chronic. She also has worked with DEBRICHEM in complex cases. We begin with two short films. The first film shows DEBRICHEM, how it works, and the second film shows the application itself, recorded in a clinic in the United Kingdom. So you can see what the procedure looks like in real clinical practice. After that, I will briefly introduce the topic of surgical site infection, and then the heart of the webinar belongs to our guest speaker, Viviana Gonçalves. We will close with the question that we hear most often, patient discomfort and pain management. But first, let's begin with the mechanism of DEBRICHEM. Let us watch what actually happens in a wound bed, and I will talk you through it. In this video, we look at the mode of action of DEBRICHEM, where we have an animated wound model and we look in how it actually works. So we see that in 90% of all the wounds, an infection comes on, and these infections by planktonic bacteria, they grow in the wound bed, and eventually planktonic bacteria can develop into a biofilm. And this actually can happen in just under half a day. In 12 hours, the bacteria move to a biofilm that is a fully matured protective layer for the bacteria to survive in. So this biofilm formation on this animated wound model shows that there is a lot of bacteria, but there is a lot of water content in that biofilm itself. Up to 97% of the biofilm is water, and the rest is just sugars and proteins. Now, we have DEBRICHEM, and DEBRICHEM is a disruptive mechanism by capturing water molecules, binding water molecules from that biofilm. 97% of water in the biofilm. So DEBRICHEM binds with these water molecules and dehydrates the wound bed with a lot of energy release by binding with those water molecules. So when DEBRICHEM comes onto the wound bed, it starts to look for those water molecules in the biofilm, in the devitalized tissue, in the infected tissue in the wound bed. You can see in this animation that the DEBRICHEM comes in and that it binds with the water molecules and releasing that energy that we were just talking about. And that energy release then goes into those proteins and sugars that are part of the biofilm, disrupting and breaking the bonds of those molecules, and therefore causing the breakdown of the biofilm and devitalized tissue. This disruption then leads to the microbial death of these bacteria by creating a very hyperosmotic state where these bacteria become very fragile. So you can see in this frame where the bacteria come into a shape that is very fragile and that they are very much reacting with the water molecules, and therefore the energy is breaking down those molecular bonds. With this A-specific method, we also have not reported any resistant mechanisms of the bacteria, and we see that the dehydration of the devitalized tissue and biofilm is causing a disruption and therefore a clean wound bed for the restart of the healing process. Now, the biofilm is then removed by the desiccation, the dehydration of DEBRICHEM, and therefore able to promote that fast healing. But what does that then mean? If we move to this next video, in this video, we look at the application process of DEBRICHEM. We have Venus Leck also here, as we are discussing in this webinar. And here we see the tissue viability nurse preparing the working area for the treatment. So this is what you go about as you would normally do. You prepare the working area with the materials you need. You prepare the area where the patient can take place. You make sure that you take the materials out that are for wound cleansing, but also for your personal protection. So you have your gloves ready and your other materials. Maybe you can wear some glasses if you want. And then you would go to the patient, make sure they are comfortable on their treatment table and you remove the dressing. And when the dressing is removed, you also inspect, of course, how the wound looks like and how it's going. Then you clean it. So you take a bit of saline and some gauzes to cleanse the wound. This is all regular wound care process. Then from there, we take on for this patient, because there is a bit sensation in the wound bed, also some anesthetic. And here we use an EWMA cream for 5%, and we left that on for 20 minutes. And after that, the wound bed site was sufficiently numbed to go about with proper cleansing and the debridement with DEBRICHEM. So here you see the removal of the EWMA cream, and then you can take on DEBRICHEM. After shaking the bottle, you pour it out of the bottle all the way onto the wound bed, but also covering the peri-wound, which is also very well displayed here. And from there, the timer has started already for the 60 seconds. It's been speed up for this frame. And after the 60 seconds, you come in with the saline or sterile water to rinse off and neutralize the effect. Because DEBRICHEM reacts with water, so it's also neutralized in plenty of water. And you can see that it's a very easy way to use the product, and also see that the wound bed really changes after the treatment. So you can see after drying the wound bed that from there you can prepare the wound for the rest of the dressing and make sure that it's covered, and you use the dressing as you would normally do for this type of wound. Then you clean up the rest, make the bandage ready, and for this case a compression bandage, as it's a venous leg ulcer, and then the patient can be sent home. You've just seen what DEBRICHEM does and how it is applied. Let us now place it where it matters for today's webinar, the post-surgical wound. The vast majority of surgical wounds heal as planned, but some do not. Some wounds open, sutures give way, and the wound begins to heal by secondary intention. At that point, the wound can enter a chronic state. Biofilm, devitalized tissue, may quietly take hold, and the wound bed may no longer support normal healing progression. To be clear, DEBRICHEM is not about prevention and is not intended for closed surgical wounds. This webinar is about wounds that have already stalled, wounds where infection, biofilm, and devitalized tissue need to be addressed as part of wound bed preparation. And theory goes only so far, so let us bring this into real clinical practice. It is my honor to hand over to Viviana Gonçalves, Specialist Nurse Consultant in Wound Care and Tissue Viability and European Wound Management Association Council Member. Viviana has managed these cases at the bedside. She will take you through her path from the beginning, being skeptical, to seeing where DEBRICHEM can fit within the wound care continuum using real patient cases. Viviana, the floor is yours.
Hello, welcome to this webinar. My name is Viviana Gonçalves. I'm a specialist nurse consultant in wound care and tissue viability. I'm from Portugal, and at the moment I'm responsible for wound care in some hospitals in Saudi Arabia. I heard about DEBRICHEM 3 years ago when I was working as responsible for all the surgical wounds in a hospital in Portugal. And because there we had a lot of issues regarding the decencies and how much problems we had after that, the company present me the topical desiccating agent that can be a very useful tool to make debridement, especially in complex wounds that most of the times need to go to the OR to provide its kind of debridement. Of course, my first thought it was what kind of tool or what kind of product product that we have now that can provide us such singularity that we don't need to go with our patients to the OR to make this kind of debridements, and especially because most of them has a heavy bioburden related, and for that it was much more difficult to remove it and to improve the healing process. I try, and I'm here now after these years and with much more experience now. And I'm going to show you how I become from skeptical for believer in this tool for debridement. So when they present me this product, they told me it was just for what they call hard to heal or chronic wounds. But most of my issues was with surgical ones, with the late decency, that it's a real problem, and facing that problem could be very, very complicated, because after surgery we want the patients heal very fast to be discharged without any issues. However, when the non-viable tissue is present in this kind of decencies, become more harder and more difficult to debride, the treatment is prolonged in time with a lot of costs regarding even the treatment and even for the patient, because the quality of life and for the families, it's very poor. So decency is really a problem to handle. What happened most of the times after surgeries, the patients have blood alterations. What is happening is most of them, the blood, they may become hypocoagulated for the surgery or not. And when they have massive blood loss during the surgery, is even more difficult for make debridements, because we can increase the risk of blood. So when we have wounds like this, for example, after a cardiac surgery, when we have in the sternum, we have a lot of slough to remove, but it's very difficult to remove because it's quite connected to the tissue. Or when we have massive extension like this, that we cannot just simply pick a scalpel and start to remove the tissue. So in these cases, in particularly in cardiac surgery, it's becoming even more difficult. So the application of the topical desiccating agent with this ingredient, the methanesulfonic acid, it's an effective tool that promotes the chemical debridement in these complex wounds. Here, I'm going to present you some cases, because I can be here talking a lot about this product, but in the end, it's much more easier if I present you how we manage, how this product work in reality with real patients in real life, because is this what you are going to do in your place? So here, it was a decency for a sternotomy, a female with 52 years old, diabetic, with COPD, high blood pressure, and hypocoagulation after cabbage. So cabbage is when they make the harvest from veins, especially from the legs, and they put it in the heart. This was my first case, so for me it's very special, because being my first case, I always like to present them, because it was my first experience. So it's going to be like who was someone that I never used this before, so I was very afraid. So this lady presents in our outpatient clinic. So this was 3 months after the surgery, with this decency, I asked her where she being making the treatments. She told me she was in the primary care, and that day she was in an appointment with the surgeon. That's why we catch her in the OPD. So we can see here a lot of fat tissue, slough, very connective slough with inflammatory signs. We cannot make a huge debridement because we don't have deconnective slough, and we can see some vicryl wires that were not be able to be absorbed by the body. So in this case, we tried the DEBRICHEM. We here, because the patient was very complaining about pain, we make an instillation of lidocaine 2% around the wound, not deep, not in the wound bed, because it was the risk to infiltrate the microorganism. We make the application, and he was complaining a lot with pain. She told me she was the worst pain that she ever felt in her life. But in that, and then we applied negative pressure for the first time. Our cases, we associated a lot of time the negative pressure after the application of DEBRICHEM. So 7 days after the application and with the negative pressure in place, what we can see is a larger wound. And if we think about the mechanism of action of the debridement, is when we take out the non-viable tissue, we are going to become with a bigger wound. However, for me, when I saw this for the first time, I thought, okay, this not seems so well that I thought it's going to be. But the company told me, you don't need to apply a second time. If you apply again, we try to take out some loose slough that was with a tweezer, we be able to do it, and we apply again negative pressure to see what is going to happen. And it was really a good surprise to see 7 days after it was improving a lot, especially in the lower wound that it was smaller. We can see it as a little bit of bleeding, and it was more, we can see more viable tissue. Okay, so, and even the inflammatory signs, they almost disappear. And here was when the patient told me, the last 7 days I didn't feel so much pain at all. So I was thinking, okay, if the patient didn't feel any pain, it seems that it's improving, because the first week was very difficult for her. So for me, I try it again, and we apply for more time. And 1 month after the first application, and just with the negative pressure, we had the wound almost closed. We close it just with negative pressure, first with negative pressure, the conventional negative pressure, and then we applied the incisional ones. We tried to approximate the edges to promote all the collapse of the wound. The pain related after the application was just in the first week, okay? I'm not going to say it's completely no pain at all. It was painful, but she told me it was not so painful as it was in the last month before he comes to be with us in treatments. And the most important thing is, in the past, these type of patients, women and obese and diabetic, with this kind of decencies, they need a second surgery for debridement and for close. We didn't need it here. Why? Because we promote these debridements. We promote the control of the biofilm. And we be able to close. And of course, if we don't need a second surgery, I don't need the patient to be inpatient, to be in the hospital. She came every single week to make a new treatment in outpatient clinic. And we apply the DEBRICHEM in outpatient clinic. Of course, we need the anesthetics and some painkiller for pain management. And in the end, it was less economic impact. If this lady went to the OR, we are going to spend thousands of euros just for the surgery of debridement, not even the closure. So here we just spend one bottle for the topical debridement desiccant agents. Now, the second case is a decency of a cephanectomy. So a cephanectomy is a wound that is in the leg and results after the harvest of the veins for cabbage. So in this case, we had a male with 62 years old, diabetic, heavy smoker before surgery. He told us that the last cigarette that he smokes, it was before going before the admission. So it was even until the last minute. Hypocoagulation regarding the aortic valve replacement and was for cabbage for veins. So this one, because it was high risk, it used prevention in the sternum. However, most of the times we don't take enough careful for the legs. So this was 1 month after the surgery. It becoming worse and worse and worse. And one day, and we didn't know what to do more, to trying to remove all this non-viable tissue and to decrease these inflammatory signs and the presence of biofilm. So we decide to apply the topical desiccant agents. We apply it, and just like in the other case, because here we have more experience, we put again the negative pressure, because we saw and we read from some evidence and some literature that say if you apply the negative pressure after this, it's going to improve the removal of the biofilm and the growing of the granulation tissue. So we make the same thing, and after 4 days, because it was a lot of exudate, the patient says it was very itchy, is not feeling very well. It was again an outpatient clinic. We see it. It was a lot of redness, but it seems like we be able to take a little bit of that non-viable tissue that was marked there in the beginning. And one of the things that make me think maybe in this patient is not going to work is because he didn't feel a lot of pain when we apply and when we wash after 1 minute. So when I saw this after 3 days, and I thought, maybe in this patient is not going to work. I see some changes, but not changes enough. Okay, here what we done, we try to apply again the negative pressure. We put some barriers, some polymeric barriers to protect the peri-wound skin. But something happens after 1 week. After 1 week, we saw a huge difference. We saw a more contractile wound with no inflammatory signs, no more significant inflammatory signs. We see that non-viable tissue was less. So here I thought, okay, maybe it was the right thing to do. And the patient told me I was much more comfortable this week. I didn't have a lot of exudate. We can see it in the machine. So, okay, let's see. One more week and we saw a huge difference. Why? We have the wound bed full of granulation tissue, no pain related with the wound, and we see the size is becoming less and less every single day. So was a very, for me, when I saw this patient week after week, I thought, okay, it was a good bet to do this, because in the end, the first week was not very good. However, in the further weeks, it was awesome because we can see a lot of evolution. However, this patient was from far away from the hospital. And when we see this 2 weeks after the application, I told them, okay, you can go for your primary care center that is near your home, because here, every time you come here, you spend a lot of money. So here I discharge the patient home. And here you can see the difference in 2 weeks, okay? Just with half of a bottle, we make the application, and then this patient don't feel any pain at all, not even in the application. That make me thought maybe this patient has some arterial disease but was not approved. We improve a lot the quality of life of this patient, and with a less economic impact. What was happening to this patient if he was not with us? He, in one moment, he was catch a major infection and maybe needs a different type of treatment. He didn't need any antibiotics since the beginning. And finalize my last case. This was one of the most huge cases that I have it. So it was a male to 72 years old diabetic with renal failure, with high blood pressure and peripheral vascular disease. It was, the surgery was aortic valve replacement and cabbage of 2 veins. So this is a huge story. Why? Because after the surgery, after 5 days after the surgery, this patient developed a decency. But the decency was clean wound, nothing, the discharge, the exudate was normal. The microbiology from the first 10 days became always negative, and 10 days after the decency, so 15 days after the first surgery, he went to the OR to make the wound closure, because it was a full decency until the bone. 48 hours after the surgery, the second surgery for wound closure, he presents with fever, with lot of purulent exudate, and with the collection of pus in the distal area of the wound in sternum, that I opened and I saw this, what are you seeing too? We make, we collect some tissue, and the result was Enterococcus faecalis. So this was a nightmare, because the patient before the surgery was okay. 48 hours after the second surgery, he was with this bacteria. So I try to put instillation with negative pressure, no results, nothing. We open all the wound. So we had a lot of slough connected to the bone, very difficult to take out. We cannot make a sharp debridement because the patient was hypocoagulated. So the thing was, I take this patient to the OR to make a huge debridement in the OR and become with an open wound, and then put instillation with a negative pressure, and we close after a few weeks, or we try to do a chemical debridement. And it's what we thought. We make that. We make the application of DEBRICHEM in this wound, and I know it was off-label use because I put it in the bone. We had a lot of slough connected to the bone, so we put it in that slough. And we apply instillation with a negative pressure. We change the instillation, we make the new dressing after 3 days and then after 4 days. We can see after 7 days with instillation, we saw a huge difference. Why? We start to see some bleeding. We still have some slough. However, we have less slough and it's more loose, so it was be able to take it out. Okay, so in here we make the first biopsy after the application, and it was negative. This was 7 days after. So we can see here that we have much more granulation tissue. The wound is growing. We cannot see so much of the sternum wires because they're becoming more covered with granulation tissue, and we saw a decreasing of the inflammatory signs. So here we make the second tissue biopsy. And here again, negative. So here we decide to take out the instillation and put just negative pressure. And 3 weeks after the first application, we saw a really huge contraction of the wound, a lot of tissue that grows with decreasing of the size of the wound. And this was just 3 weeks. 2 weeks after the application, the surgeon spoke with me and told me, okay, when you saw that he's prepared for closure, we can go to the OR and promoting the wound closure. And I say, okay, don't worry, we are going to take out the instillation now and we will see next week. But when I saw this 7 days after, I thought, okay, maybe this patient is not going to need to go to the OR. Why? Because it grows so fast that more 7 days, and we have like this. So this last picture, it shows you 4 weeks after the application of DEBRICHEM. And here we were a few days before Christmas, and we decide to discharge the patient home to spend Christmas with the family, because we can give him a portable machine because they don't have a lot of exudate at all. And this 52 weeks after the last one, after discharge, he came every single week to the OPD to change the dressing. And this was 3 months after the application of DEBRICHEM. We didn't need to go to the OR to make the closure of the wound. So we closed again with negative pressure, no pain. We discharge after 3 weeks of taking out when we applied the first instillation. No need for plastic surgery for skin, for flap, and of course, improvement of quality of life with the less economic impact that you can imagine. So, what we can conclude for this? For conclusion, I can tell you that, debridement is the first step for healing. Of course, we need to take out what is in the wound bed that is not making okay. If we don't debride, we are not going to have healing. And when we use things like this, we need to keep in our mind that pain control is fundamental to keep it and to be with the patient. DEBRICHEM is a very important tool to eliminate bioburden, to eliminate biofilm. Because why? Because it promotes the desiccating of the bacteria. So it removes all the water. Its cost effectiveness. You can tell me, oh yes, but each bottle are very expensive. And it is, of course. However, you need to understand how much costs went with a patient to the OR to make a debridement, how much cost to the patient to have to go 3, 4, 6 months to treatments every week or every 2 days. So yes, it's expensive, but in the end is not. And this, for me, it was the most important thing, that one of my patients was discharged and spent Christmas with his family. So this was what I have to tell you. I hope that you really understand the importance of the use of the tools that we have. Of course, we need to make a full assessment, an holistic assessment. I'm not saying this is for all patients, of course not. But when you have a patient with a non-viable tissue that is becoming harder and harder to remove, maybe you need to think in this kind of approach, because it's going to be painful in the beginning. You need to make pain management. You need to wash that very well after the first minute, and then you need to put or make the right treatment to improve the action of what you make first. Any question, any doubt, this is my email. You can contact me. Thank you very much.
Thank you, Viviana. You've raised a question we hear almost in every conversation, so let us address it openly. Yes, DEBRICHEM can create an uncomfortable sensation during application. The mechanism works by desiccating infected and devitalized tissue, and patients can feel that. What matters is that this discomfort is predictable and manageable, as we also indicate in the application video at the beginning of this webinar. Now we have peer-reviewed evidence on this topic. A study published in the Journal of Wound Care in 2025 looked specifically at pain perception and pain management during the chemical debridement with a topical desiccating agent. The study included 20 patients, and the pain was measured on a standard 0 to 10 visual analog scale before, during, and after the treatment. 2 ready-to-use local anesthetic approaches were used, an anesthetic cream and a tumescent local anesthesia. With these approaches, pain during the application was in the same range as sharp debridement, and in the same patient, sharp debridement was rated slightly higher, around 1 point higher on the scale. So practical takeaway is simple. Plan for the expected discomfort, use local anesthesia, and prepare the patient properly. With that approach, DEBRICHEM can be used in a way that compares well with sharp debridement in relation to pain, while keeping the procedure in the outpatient clinic and out of the operating theater. The reference to this study is provided in the comments below. And that brings us to the close. Thank you for spending this hour with us, and thank you for the work you do every day with wounds that are rarely simple. Before you go, 3 quick things. First, the full reference list and evidence pack are available in the chat, including the pain management study that we just discussed. Second, if you would like to walk through a specific case or see DEBRICHEM in your own setting, our team is just 1 message away. The details are on your screen. And finally, a warm thank you to Viviana for sharing her knowledge, experience, and patient cases so generously. In case you have any questions or want to try DEBRICHEM in your clinic, feel free to reach out. We will post a link where you can submit a request for demonstration. And following the request, our distribution partner in your respective country will get in touch to schedule a clinic visit and treat 3 to 5 patients together with your team. To all of you, take care of yourselves and of your patients. We hope to see you soon again.